So today we're going to discuss something about spastic paraparesis, and I'm continuing with my Mrcp basis consultation station presentations. Remember that this case you can get in your consultation station as well, in your neurology station. So be prepared for this. This is a very common case. So let's move on. So normally once before you enter the consultation station, there is some information written outside, so it's very important you read through that information, get some idea about the system, which system you'll be focusing for examination, and then structure your presentation and brainstorm about the differential diagnosis. So this is Mr. Smith, 48-year-old gentleman. He's referred to the neurology, and chief complaint is gradually progressive difficulty in walking over the past year. So he described this as a stiffness and weakness in both of his legs. So it's make it challenging to initiate movements and maintain balance. And he mentions that his condition has affected his bladder control with increased urgency and occasional incontinence. He denies any sensory abnormalities, significant pain, or autonomic symptoms. Here I've given a lot of details actually in the patient presentation. Maybe you'll not get so much detail. Maybe just gradually progressive difficulty in walking and stiffness and weakness. That's it. Okay, let's move on. So once you know this, you just brainstorm and you already know that this is a neurology case and there is some stiffness involved. So you'll be thinking about the spastic paraparesis or something about the upper motor neuron lesions. So in the history, I have divided the history into points so that you don't miss anything. So we're going to ask about the onset and progression. Now the onset may vary. If it is a sudden onset, then probably the cause is related to spinal cord, maybe because of spinal cord infarction. And if the patient gives history of gradual onset, this is indicative of progressive conditions, like we're talking about hereditary spastic paraplegias or multiple sclerosis. Then you have to ask about the specific symptoms, nature of the symptoms, because it helps distinguish between the stiffness, weakness, or a combination of both. Now, for example, if there is a pure spasticity and there is no weakness, then it is more suggestive of the hereditary spastic paraplegia. While in another case, if the patient says there is a spasticity and weakness, then maybe some other causes. We'll discuss it later. Second thing is you have to ask about any sensory changes like numbness or tingling, because these sensory changes, if it is present along with the spasticity, then it is more suggestive of a demyelinating condition like multiple sclerosis. So first of all, onset and progression, then you also ask about the specific symptoms. Bladder and bowel function, obviously going to be very, very important, you must ask. Changes in bladder or bowel functions particularly relevant. So neurogenic bladder, like urinary urgency, incontinence, or difficulty voiding, it may point towards spinal cord involvement. So neurogenic bladder, then thinking about the spinal cord. Bowel dysfunction, including constipation or incontinence, also indicative of spinal cord issues. Okay, so let's move on. Then you're going to ask about any pain and discomfort. So understanding the character of the pain or discomfort, this can help distinguish this neuropathic pain from musculoskeletal discomfort or spasticity-related discomfort. So if the patient says got muscle spasm or cramps, then it is more common in spastic paraparesis, and it can provide additional diagnostic clues. Ask about any triggering factors, like sometimes if there is a physical activity which is exacerbating the symptoms, this might be suggestive of conditions like spinal stenosis or maybe some mechanical compression. If it is triggered by changes in position, that is orthostatic changes, so if the changes in position worsen the symptoms, may be seen in conditions like normal pressure hydrocephalus. So ask about these triggering factors. Then previous medical history, obviously very important. So any existing medical conditions, especially neurological or hereditary disorders, these are critical to explore, as some patient may already have a known predisposition. So prior surgeries are very important, or any spinal procedures or are important to assess, because post-surgical complications can lead to neurological symptoms. Family history is important. A family history of hereditary neurological condition is relevant in cases of hereditary spastic paraplegias or other genetic disorders. Ask about any medication and supplements. Medication history is vital because certain drugs may influence symptoms presentation. Over-the-counter medication or supplements, they might be associated with side effects or interactions. Then you're going to ask about any social environmental factors like smoking, alcohol, and occupation exposure. It can help assess potential risk factors, like certain industrial or environmental toxin might be linked to neurological symptoms. We will take a travel history as well, because recent travel history and exposure to endemic infection, especially in areas with vector-borne diseases, it can be relevant for infectious or inflammatory causes. A history of recent infection could suggest a post-infectious inflammatory etiology. And finally, explore the psychological factors. Acknowledging the patient emotional state and life circumstances is crucial, because stress and psychological factors, it can sometimes manifest as functional neurological symptoms. Okay, so this is all about the history. Try to cover all the points, and then by taking the history, you already have your differential diagnosis, and you'll be able to exclude top 2 or 3 diagnoses, and it will be quite helpful once you go for the examination. Here I've just added some more information about the differential diagnosis of the spastic paraparesis, because you must have a good grip about the differential diagnosis of this condition. It will be quite helpful when you present your case. So what could be the differential diagnosis? First of all, I'll talk a bit about multiple sclerosis. So it is demyelination of the central nervous system, and it can cause a lot of neurological symptoms. Spastic paraparesis can occur as part of clinical presentation along with other sensory or motor deficit, and we all know that MRI of the brain and spine can help in diagnosing multiple sclerosis. Remember, multiple sclerosis history is also very important, because most common type of multiple sclerosis is relapsing and remitting. So it causes relapsing remitting cause. So if you ask the patient may recall some history that he had some eye problems or some diplopias or some numbness sensations in the limbs. So that is very important. Other differential diagnosis for the spastic paraparesis, spinal cord compression, and it can result from various causes. It can be because of the hernial discs, it can be herniated disc, it can be spinal tumors or spinal stenosis. So compression of the spinal cord, it can lead to spastic paraparesis. So again, imaging studies like MRI are crucial for identifying these structural issues. And your MRI you're going to do in all the cases of spastic paraparesis. So number 3 is hereditary spastic paraparesis. These are a group of genetic disorders, and it leads to progressive spasticity and weakness. So as I already mentioned to you, if it is in sudden onset, then you think about the spinal cord. But if there is a progressive, then you think about the hereditary conditions like hereditary spastic paraplegia. So in this, the family history is very important, and we know that genetics testing are essential to diagnose this condition. Moving on to a differential diagnosis, infectious or inflammatory myelopathies. So infections like human T-cell leukemia virus 1 or any autoimmune conditions like transverse myelitis can cause spastic paraparesis. So in these cases, we have to do some additional tests like lumbar puncture, and the serological tests may help to investigate these possibilities. Vitamin B12 deficiency, well, subacute combined degeneration of the spinal cord due to vitamin B12 deficiency, it can cause spastic paraparesis. So assessing the vitamin B12 level is critical for diagnosis. Cervical myelopathy, well, conditions which affect the cervical spine, like cervical spondylosis, can sometimes it can manifest as spastic paraparesis. Even the problems are higher in the spine, so patient may have some symptoms in the upper limbs as well. Vasculopathies, well, conditions like spinal cord infarctions or AV malformation, this can lead to spastic paraparesis. Obviously, imaging studies will help to diagnose this vascular diagnosis. Now, this is quite broad actually, but if you can remember, 5 or 6 should be enough. So another differential is neuromyelitis optica. It's also known as Davick's disease. It can present with extensive transverse myelitis and spastic paraparesis. And in this, we have aquaporin 4 antibody testing, which is essential for diagnosis. HIV-associated myelopathy. So in individuals with HIV, myelopathy can occur and can lead to spastic paraparesis. So obviously, a detailed medical history, HIV testing, and clinical assessments are required. Then psychogenic causes, although quite rare, psychological factors can lead to functional neurological symptoms resembling spastic paraparesis. So obviously the thorough psychiatric evaluation is essential. And medication, finally, medication-induced myelopathy. Some medications, like certain antipsychotics, they can induce myelopathy and spastic paraparesis. So a detailed medication history is crucial. So, my dear doctors, these are all the differential diagnoses which you'll be thinking about in the case of the spastic paraparesis. Okay, let's move on now to our examination. So on examination, first of all, you're going to do the general examination. So just observe the general appearance, look at the gait, whether this is a spastic gait or body habitus. So the patient may exhibit an abnormal gait like spastic gait or stiff leg walking. Then you'll do the neurological examination. So neurological examination, we're going to, because he says the symptoms are in the lower limb, so we're going to start with the lower limb examination, testing tone in the lower extremities, assessing for the spasticity. So we expect the muscle tone to be increased, and they'll be rigid. So increased muscle tone and spasticity in the lower limbs, these are characteristic of spastic paraparesis. Then we're going to move on and do the muscle strength assessment. So there will be weakness, typically in the lower extremities may be observed. And you can use the MRC scale to grade your weakness, grade the weakness, how much is the weakness in the lower limbs. Now, reflexes, check the reflexes, because we expect the reflexes to be exaggerated or hyperactive. Exaggerated or hyperactive reflexes, such as brisk patellar reflexes, these are common in spastic paraparesis. Obviously, this is upper motor neuron lesions. So assess the sensory function in the lower extremities. So we do all modalities, light touch, pinprick, and proprioception. So sensory abnormalities may be absent or limited. So remember that sensory abnormalities, they normally are absent, as pure spastic paraparesis primarily involves the motor symptoms. Then you're going to do check for the coordination and balance. So by evaluate the coordination by heel to shin testing, finger to nose testing. So we're looking at any cerebellar element, and coordination deficit may be observed, especially if the condition has progressed. It may be not there, but difficult to do because if the patient has spasticity, then maybe the coordination will be difficult to elicit. Gait assessment. So observe the patient gait carefully, noting any abnormalities like spastic gait, scissoring gait, or circumduction. So abnormal gait pattern like spastic gait, it is often seen. We discussed it already. And for the bladder function, obviously you cannot assess the bladder function, but we'll just ask in the history about any urinary urgency, incontinence, or difficulty voiding, because all these indicate the spinal cord involvement. Then you're going to mention about doing the perianal reflex, because you're not going to do, obviously. We expect the absent or reduced anal reflex, and it suggests the spinal cord involvement. So it just suggests that I want to do that one maybe at the end of the presentation. And Babinski sign, obviously, it is part of the lower limb examination. We test this Babinski sign, and abnormal response we expect with the dorsiflexion of the big toe with fanning of the other toes. And these are suggestive of the upper motor neuron lesions. So, my friend, this was all about the examination. So, start with a general examination and proceed to the neurological examination and do the complete neurological examination. So, how will you manage the patient? I just put brief notes about the management. So, obviously, management depends on the underlying cause. Suppose if the patient already given the very long history, then thinking about the hereditary spastic paraparesis, then the genetic counseling is important for confirmed case of hereditary spastic paraplegia. It can help the patient to understand the inheritance pattern and assess the risk to the family members. And additionally, can make informed family decisions. And there's not much can be done, but symptomatic management. So it involves the physical therapy to improve gait and mobility. We can take the help from some assistive devices like orthotics or canes and antispastic medications if necessary. Now, if the cause is multiple sclerosis, we know that we have disease-modifying therapies for relapsing form multiple sclerosis, and can help to reduce the frequency and severity of relapse. And obviously, there is symptomatic management, which include physical therapy, muscle relaxation for spasticity, and pain management for neuropathic pain. So we divide into two: symptomatic therapies and symptomatic management. Disease-modifying therapies, and symptomatic management. What about the spinal cord compression? If there is spinal cord compression you're suspecting, then the treatment is surgery. Like herniated disc or spinal tumor stenosis, then surgical decompression may be necessary to relieve the pressure on the spinal cord. And obviously it will be followed by the physiotherapy. If we're thinking about any infections or inflammatory myopathies, then obviously we want to do the treatment of the underlying cause. Antiviral medications or immunosuppressive therapies may be required to manage the infections or inflammatory conditions. And obviously the rehabilitation part will play a role with physical and occupational therapy, can help with the functional recovery. So what about the nutritional deficiencies? So if we suspect nutrition deficiency, we done the test, vitamin B12 is low, then we correct the vitamin B12 or other nutrition deficiencies with appropriate supplementation. Neuromyelitis optica, we have to do the immunosuppressive therapy, and sometimes we need a plasma exchange may be used to manage neuromyelitis optica. And symptomatic management is similar to MS, like improving the mobility and managing the spasticity. If it is psychogenic causes, then we want to do the psychological evaluation for functional or psychogenic causes. Psychiatric evaluation and psychotherapy may be necessary. For the cervical myelopathy, again the surgical decompression may be required, and is followed by the rehabilitation. So in cases of vasculopathies, we have to do some vascular interventions. So management may include the endovascular procedure or surgery to address the vascular lesions. So this is briefly about the management, about the different causes of the spastic paraparesis. Sorry, I've doing too many repetitions, but these are necessary so that you remember these things in your exams and don't miss anything. And remember, in any part of management, remember this thing, multidisciplinary approach. This is a buzzword, you don't forget it. This is crucial for comprehensive patient care. Like we need the physiotherapist to help improve the mobility, strength and coordination. We need the occupational therapist, which focus on enhancing activities of daily life. We need help from the pain management clinic for neuropathic or musculoskeletal discomfort. We want the neurological consultation as well, and we need the psychological support. So remember these multidisciplinary approach, and remember all the departments which we're going to involve in the management of the spastic paraparesis. Okay, now I'm going to do the brief presentation. So you already have done your history, you've done your examinations, you already have brainstormed about the differential diagnosis. So how you will present the case obviously depends on what was the history and what was the examination findings. So this is just an example that how you should present. So obviously, first of all, going to do your introduction. Good morning or afternoon. My name is this, and no need to say I'm a candidate. I will just say my name is this. One of the doctor working here. I would like to present a case of so and so who present with the chief complaint of spastic paraparesis. So this is about the introduction part in your presentation. Then you'll move on and talk about the history, the patient symptoms, when it began, and how was the onset, was it gradual or sudden, and how the patient describes the symptoms as what was the nature of the symptoms. There is no significant past medical history of note, and the patient has not had any recent surgery or hospitalization. So these are very, very important points, important negatives, that no significant past medical history and no recent surgeries. So remember, in your presentation, you're going to talk about the introduction first, you give the brief history, and then you talk about your clinical examination findings. So on examination, observe the patient gait, which appears to be spastic. Muscle tone in the lower limb was increased, so was evidence of spasticity. Motor strength in the lower extremity was assessed using the MRC and found to be 3/5. And deep tendon reflexes were brisk in the lower limbs, and there was a positive Babinski sign. Sensory examination revealed there is absence of any sensory abnormalities in the lower limb, and coordination and balance testing demonstrated normal results. So remember these things. This is because when you will be systematic and tell about all the positive and important negative, the examiner will be very happy and will give you a good marks actually, because you have almost covered almost all the things in your presentation. Then you will move on. So after the introduction, first of all introduction, then we go to the history, we go to the clinical examination, and then we'll talk briefly about the differential diagnosis. So the differential diagnosis for this patient include, again, depends, gradual onset, sudden onset. So if it's a gradual onset, we say hereditary spastic paraplegia. We'll be thinking about the multiple sclerosis, spinal cord compression, nutrition deficiencies, neuromyelitis optica, psychogenic and cervical myelopathies or vasculopathies. Then the examiner may interrupt you, ask you, what is your most favorable diagnosis? Then, considering your examination and history, you'll tell the top diagnosis first. And then you'll mention in your presentation about the investigation. So to determine the underlying cause, I would consider the following investigation. So you mentioned that first of all, you like to do the MRI of the spine to assess for any structural abnormalities or demyelinating lesions. Genetic testing, well, it is important, hereditary causes are suspected, and serological test to assess if there is any infectious or autoimmune etiologies. Vitamin B12 levels will be important to evaluate any nutrition deficiencies, and if you suspect any neuromyelitis optica, then aquaporin 4 antibody testing will be helpful. So in your presentation, not stop there, and again you will talk about the management. So management will depend on the confirmed diagnosis, but may include the physiotherapy, physical therapy for gait and mobility improvement, pharmacological treatment, that is for the spasticity, surgical interventions for structural causes, or immunosuppressive therapies for autoimmune conditions, and pain management strategies. So remember these points in your mind, so that at that time you don't get caught in the moment, and sometimes we just are blank and we cannot answer anything. So remember in the management at least these points, so you at least can say something. So, and then you will conclude your presentation by summarizing it. In summary, this case involves a patient with spastic paraparesis. A comprehensive evaluation, including clinical assessment and appropriate investigation, is essential to determine the underlying cause and guide treatment. So this is, my friends, how you're going to do your presentation. Start with the introduction, and then we move on to the history, then we move on to the clinical examination. What are your findings? We talk a bit about the differential diagnosis, investigations, and finally management and a brief conclusion. Okay, so now I'm going to talk a bit about the common questions which could be asked in this case. Examiner could ask what are the common causes of spastic paraparesis and how do you approach the differential diagnosis. This is just an example. So you can answer that spastic paraparesis can result from various etiologies. In our case, the differential diagnosis include hereditary spastic paraplegia, multiple sclerosis, spinal cord compression, can be infectious or inflammatory myelopathies, nutrition deficiencies, neuromyelitis optica, psychogenic causes, cervical myelopathy, and vasculopathies. So to approach the differential diagnosis, I consider the clinical presentation, examination findings, and relevant investigations to identify the underlying cause. So mainly a repetition of what we have already discussed. Another question which examiner could ask, what specific clinical findings led you to consider multiple sclerosis in the differential diagnosis? So depends how the case is revealing. So in considering multiple sclerosis, I noted the presence of spasticity in the lower limbs, which is consistent with spastic paraparesis. Additionally, the patient history, it may reveal previous episodes of neurological symptoms that come and go, or optic neuritis. So to confirm the suspicion of multiple sclerosis, I will recommend an MRI of the spine to assess for any demyelinating lesion, as well as detailed review of the patient clinical history. Another common question which could be asked, you mentioned genetic testing. Can you elaborate the role of genetic testing in diagnosing hereditary spastic paraplegia? So genetic testing, remember, it plays a crucial role in diagnosing hereditary spastic paraplegia, because the HSP actually is a heterogeneous group of genetic disorders with numerous known gene mutations. So this information not only confirms the diagnosis, but it also provides insights into the inheritance pattern, about the prognosis and potential risk for the family members. So genetic counseling is often recommended to facilitate a better understanding of the condition within the family. Another questions which are asked is, you mentioned the possibility of surgical intervention for spinal cord compression. What type of spinal cord compression condition might require surgical treatment? So spinal cord compression can result from conditions like, we know already, it can be herniated disc, a spinal tumor, spinal stenosis. So surgical intervention may be indicated when there is evidence of structural compression causing neurological deficits. So this is the keyword, if the patient has a neurological deficit. For instance, imaging studies reveal a herniated disc or a tumor that is pressing on the spinal cord. Surgery may be performed to decompress the spinal cord and alleviate the symptoms. Okay, so this is my final slide. So another important question is, what is the significance of Babinski sign and why it is relevant in this case? So Babinski sign is a neurological examination finding where there is dorsiflexion of the big toe and often fanning of the other toes upon stroking the sole of the foot. So we're going to describe basically what is Babinski sign. So it is a sign of an upper motor neuron dysfunction and is indicated it is a pathological reflex. So in this case, the presence of positive Babinski sign suggests an upper motor neuron lesion and which is consistent with spastic paraparesis. This sign is relevant as it supports the clinical findings of spasticity, and so it supports these signs, spasticity and hyperactive reflexes. So that's all for the spastic paraparesis. Hopefully I have given you a detailed knowledge about this problem, this disease, and hopefully you can remember this and can do well if you came across this case in your consultation station. You can get this case in your neurology station as well. Thank you very much, my dear doctors, and I'll see you in my next presentation.